Sure. I'm Joe Allen. I'm an assistant professor at Harvard's T.H. Chan School of Public Health, where I direct the Healthy Buildings program. But maybe more relevant to this conversation is my expertise is in exposure and risk science, specifically in how to keep workers safe and healthy in indoor environments.
If somebody's obviously coughing or sneezing, we can see how they could spread the virus. But what about if they're not?
Yeah, this gets down to the crux of the issue of why we have to wear masks and take these precautions. If someone is sick, they should stay home. And so in a lot of ways, that's easier to minimize future transmission. The harder part is we know asymptomatic transmission is happening. You or I could have it right now and not know it. And what people don't recognize is that you don't have to just cough or sneeze to transmit this virus. When I'm talking, or when anybody's talking, we're emitting aerosols of all different sizes, large and small. Some drop out quickly and some stay in the air for longer periods of time. This is why it's absolutely critical we have to wear a mask and assume that we may be infectious so we can protect others. The mask protects others.
There's been a discussion about aerosols versus droplets. Can you distinguish between them, please?
Yeah, I'm really glad you asked this because my field has been talking about this since February, the need to recognize that airborne transmission is happening. So let's demystify this just a little bit. There are three modes of transmission. We should start there. Large droplet, this is if I cough or sneeze, the types of particles that will settle out quickly. And that informs the strategies of staying back 6 feet, wearing a mask to limit that spread. Second mode of transmission is fomite or contaminated surfaces. The control strategies there are washing our hands and cleaning and disinfecting surfaces. The third mode of transmission, the one that hasn't been getting enough attention, is airborne transmission. And here again, these are the particles that will stay aloft for several hours. So if I cough or sneeze, some particles will settle out, but some will stay aloft. The control strategy here are healthy building strategies like bringing in more fresh outdoor air and increasing filtration. If you look at the case studies, if you look at the epidemiology, if you look at the air sampling results, we know airborne transmission is happening. And in fact, it's accounting for a greater percentage of the spread than is being acknowledged.
Do we have any sense of what percentage of the spread?
We don't. And here's the thing that it maybe is a little frustrating. We may never know. Look, for influenza, we've been studying this for decades. We still don't know. There's still widespread disagreement. So, but here's the thing. To me, it's completely irrelevant to our control strategies. If I told you that airborne was 2% of the spread or 10%, would it change your control strategy you'd put in place? No, you would never say, well, it's only 2%. Let's not dilute the air by bringing in more ventilation or increase filtration. It's only a minor percent. I don't think anyone would ever say that. So in a lot of ways, it's important to understand from a scientific standpoint and to know where to deploy our resources. But at the same time, we should just be putting everything we have at this and attacking all three modes of transmission. I'm not saying we should only be focused on airborne. I'm just saying it has to be included in our control strategies and given the same attention that we're giving to large droplet and contaminated surfaces. If you and I are talking like this and we were face to face and I was coughing and infectious, I would release large droplets, I would release aerosols, and some of these droplets would contaminate surfaces and lead to potential fomite transmission.
How sure are you that airborne or aerosolized transmission is occurring?
I've done forensic investigations of sick buildings for over 10 years. And I saw telltale signs that airborne transmission was happening in late January. I wrote my first piece in late January, published in early February, calling out the potential for airborne transmission based on what was happening on the cruise ship. Since that time, every single piece of new scientific evidence supports that notion. There has been nothing presented in the scientific literature that debunks that. In fact, the case studies, like the choir practice, like this hospital outbreak investigation that just occurred, all further support the evidence that airborne transmission is happening. The concerning part to me is that if you look at the investigations that are done, the official investigations, for example, of the choir practice, they don't mention ventilation. In fact, they didn't even look at it as a potential. But if you look at the fact pattern, it shows airborne's happening.
For our viewers who don't know, when you reel off these things like the cruise ship and the this and the that, they might not know what it is, and then we would have to set it up. So can you go through some of the most compelling evidence that airborne transmission or aerosolized transmission is important?
Yeah, I mean, we can look at it a couple different ways. One, we can just look at aerosol physics, right? If I'm coughing and emitting large droplets, I'm also emitting aerosols that can stay aloft for longer periods of time. So we can look at it that way. We can look at the air sampling data that shows we're detecting this virus in places that could only be reached through airborne transmission, like in the ductwork. But let me talk about some of these case studies, which I think are compelling, and it really falls to my, fits my background in doing the forensic investigations. Take that choir practice where we had 60 people at a choir practice, one person was sick, and 52 others ended up contracting COVID-19. 2 of those people died. In the ensuing investigation, they looked at and concluded that fomite transmission was happening, contaminated surfaces, and large droplet. But if you look at the fact pattern, it tells a different story. Here's the first thing that caught my eye. The choir practice took place between 6:30 and 9 p.m. at night. You know what happens in buildings at that time? The ventilation system is usually shut off. So that's one thing that tipped me off that maybe something interesting was happening there. But more importantly, look at this, break it down and do a process of elimination. If it was fomite transmission, we know from that fact pattern that people were handling their own chairs. It's unlikely that one person could have infected over 50 just from touching the same surfaces. Same thing for large droplet. Could people have been exposed and contracted from large droplet? Absolutely. In fact, we probably see that the person who was sick and singing infected people next to them. But they infected people who weren't even anywhere near them, which suggests the potential for long-range transport, which is what we're talking about here in terms of airborne and aerosol. So if you put together these facts, it doesn't mean droplet didn't happen or fomite didn't happen. It just suggests that airborne is also a contributor in this case, and it was ignored. It was not included in the investigation.
In the write-up, they do say, well, aerosolization could have played a role.
Yeah, it's totally minimized, and here's the problem with that. The investigation, quite unbelievably to me, did not look at the building systems. Had they looked at the building system and simply asked whether or not the mechanical ventilation system was running at the time, would have been a huge tip-off that the building system was related to the exposure. They didn't thoroughly investigate the potential for airborne exposure, and they minimize it related to the other modes. And this has happened over and over.
So if people thought that airborne transmission were more important, then they'd be looking more carefully at possible causes and maybe get to better solutions?
Yeah, I mean, this is where I come from, right? I thoroughly believe that we can save lives and the economy. And to do that, we have to look at the science and understand how we're being exposed and then line up the appropriate control strategies. It doesn't make sense to me that we're eliminating an entire mode of transmission and therefore eliminating an entire set of control strategies. Take a recent op-ed of the New York Times where some leading figures at universities were talking about the return to campus policies and practices. They laid out many of the strategies we should be doing: wearing a mask, hand washing, physical distancing. That's great. They failed to mention or even acknowledge the role of the building and healthy building strategies like ventilation. So it's clear that this message is not getting out, and these are good practices. I've been writing since February. I think it's every 2 weeks I've had an op-ed out how to protect yourself and your family at home. One of the strategies, open up your windows. Let the rooms breathe. We've spent 40 years in this sick building era because we've tightened up our building envelopes so much. We've choked off the air supply. We've stopped letting our buildings breathe. And I'll tell you something interesting here. If you look at the standards that determine the ventilation rates in buildings, they're set based on energy in response to the energy crisis in the 1970s. Do you know what the ventilation standards were set for prior to that? They were set for health, including infectious disease transmission. So somewhere along the way, we lost our way. It was actually starting in the 1970s, and we can track that time point as the beginning of the sick building era. And that is where we are right now. We have buildings that are chronically underventilated, schools, offices, homes, and we're not recognizing the potential for airborne, which means we're not trying to address that issue, that buildings are not bringing enough outdoor air. I also don't understand what the downside is here. If I'm wrong, what, people open up their windows a bit more? We bring in a bit more air into our buildings, which we know has other benefits beyond infectious disease transmission. I don't understand the reluctance to acknowledge this or to put in appropriate control measures.
Opening up the windows is easy and cheap, but what about actually changing the ventilation system of a big building?
Yeah, so here's the thing. All of the recommendations I've been making in these articles going back several months now are intentionally, I'm intentional about the types of strategies we can deploy so that they don't cost more money and that almost every building can do right now. So I'm not saying people have to go out and revamp their entire mechanical system, put in some new air cleaning technology, put in UV lights in the ductwork. It's really getting back to the basics of public health and healthy buildings. bring in a bit more outdoor air, which most building systems can do. And if you're recirculating air, you need to improve or put in a higher efficiency filter, specifically a Merv 13 or greater, MERV, Merv 13 or greater. These are the basics. They're not that expensive. These filters cost a couple dollars more. And so there's this misnomer out there that these healthy building strategies have to be expensive strategies. In fact, every building can be a healthy building. It doesn't cost that much to get us there. The Merv system is a rating system for filters. A building typically has what is known as a Merv 8 filter, which captures a small percent of airborne particles. That's why the recommendation is to increase to a Merv 13 or higher, which can capture more, greater percent of the airborne particles. Most people are not familiar with Merv rating systems, but a lot of people are really familiar with HEPA. You've maybe seen a portable air purifier that has a HEPA label on it, and maybe you've seen 99.97% of particles captured. That's telling you it's the ability of that filter to capture particles. And the reality is, or maybe the misunderstanding is that that's the highest rating. It turns out that rating is for the worst performance of that filter, specifically particles of 0.3 microns. The bigger or smaller, the efficiency is actually greater than 99.97%. And here's another thing that people could consider in terms of a supplemental strategy. If your building can't handle the pressure drop that comes with pushing air through a better grade filter, you can think about supplementing that with portable air purifiers that have a HEPA filter. These can be effective at controlling indoor airborne particles if the portable air purifier is sized correctly, the size of the room it's in.
What can somebody do at home to improve the air quality?
Yeah, the goal here is to take the science and simplify it, not dumb it down, simplify it into some actions people can take.
Do you have any kind of a sense of how effective these measures are?
Yeah, well, it's this idea here that there's no such thing as zero risk, especially in a pandemic. And what we're trying to do is layer enough strategies on top of each other that we reduce risk to a sufficient level. No one intervention is sufficient by itself. It's really hard to assign a percent reduction to each measure. How much does hand washing reduce? We don't know. How much does mask wearing? We don't know. We do know that collectively, the science supports each one of these as an intervention strategy, just like bringing more fresh outdoor air. We've known for decades of research that higher ventilation rates are associated with lower infectious disease risk. So while it's hard to assign a specific percent to it, we know that collectively, these actions have a benefit. Importantly, the benefit is to the individual. It reduces your individual risk, but it also reduces population risk. So we can minimize or protect ourselves while also doing our part to protect everybody.
As people venture outside their homes, what do they need to think about in terms of keeping themselves safe?
Yeah, I think it comes down to staying smart. And here's a nice, easy acronym for you. S is stay home, especially if you're sick. M, mask when outside your house. A, avoid large gatherings. R, refresh that indoor air. And T, 10 feet is better than 6. Think about all of those as the strategies to protect yourself and also protect others. So, you want to be outside, but you don't want to be in large gatherings. You want to stay 6 feet away from people, but that's a minimum. 10 feet's better, 20 feet's even better. And then if you're inside enclosed spaces, you want to be sure you have enough outdoor air coming in. You want to refresh that indoor air.
What can restaurants and stores do to improve the safety?
Yeah, the same principles apply. I always start with the science, modes of transmission, line up the controls. These broad principles apply. All of these basics you've been hearing about: maintaining physical distancing, hand washing, cleaning, disinfect surfaces, higher ventilation rates, filtering that recirculated air. All of this is going to work. And then you have to start thinking about, okay, specifically, what about retail or restaurants that's different from maybe a school or an office? And here it's really going to be about managing flows of people, right? To be sure we're not having people bunching up at one counter, or the traffic is not crossing, right? You can set up flows of people in your space. You can think about plexiglass barriers at the cashier to protect your workers who may be seeing hundreds of people a day or maybe even an hour. So I think we just have to then start to tailor these controls, but start with the basics of disease risk mitigation and then tailor it to the specific venue.
What are the role of masks?
Everyone should be wearing masks. This debate is over. I wrote about this in the Washington Post maybe 2 months ago. There's a fourfold public health benefit here. The first, it prevents me, if I'm sick, from infecting you. 2, it does provide some benefit to me if I'm talking to someone who is sick through at least a little bit of filtration. It's one more potential barrier. It's not as good as an N95, but it does provide some benefit. 3, it's a reminder not to touch your nose or mouth, which we know is a way to transfer the virus into our bodies. And 4th, and maybe most importantly, it's an important social cue. It's a reminder to all of us that something big is happening here. And if you see someone with the mask, everyone should be giving each other space. You should be wearing your mask. It's a sign of respect for others, acknowledging that you may be infectious. You're recognizing that. You may be asymptomatic, and you're doing your best to protect them. So wearing a mask provides a lot of benefits. We should all be doing this. And in fact, in some locations, it's the only control strategy that will work. I think about things like an elevator, where there's very little other control strategies you can put in place, and mask wearing is going to be critical.
We're being told that the mask prevents somebody else. If I'm sick, stops me from maybe contaminating them. But we're not hearing that it protects the person who's wearing it as much.
Yeah, I mean, the masks, and we're talking here about surgical masks or homemade 100% cotton cloth masks, are not N95 certified masks that are going to protect the wearer to that level of or degree of protection, 95% removal efficiency. But they do capture or filter some level of those particles. It's going to depend on how well it's fit around your face, whether it's, does it cover your nose, around your chin, how much leakage is coming in from the side, what's the material the mask is made out of. But there is some evidence that even 100% cotton mask or other fabrics can do a decent job of filtering out some of these airborne particles. It falls on the line that something is better than nothing. We know we're in a shortage of PPE, professional PPE, that needs to go to frontline workers and essential workers. So the rest of us should be using these homemade 100% cotton cloth masks or surgical masks in the interim.
I wonder if you could talk about, I saw a couple of dramatic laser videos at the New York Times and elsewhere, New England Journal, where they just showed somebody having normal speech, and then they had a shot of laser, and you could see the stuff coming out, and then they put on a mask. A few of them were from the NIH who did this, and you saw that the number of particles dramatically went down. We're not going to be interviewing those people. Do you know about those studies? Can you talk to that?
Yeah, I mean, there's been some great studies out there that actually visualize what we know is happening based on just particle physics. And what they do is they look at, using laser lights, you can actually see the particles that are ejected from someone's mouth when they cough, sneeze, and maybe most surprisingly, even when they just talk. So right now, as we're talking, we are emitting particles and fine aerosols. Some settle out and some stay aloft for a long time. And what these clever researchers did is they just found a way to visualize it so people could actually see it. Then they went a step further and said, well, what happens when somebody wears a mask? And they show that when someone wears a mask, the physical barrier actually prevents many of the droplets from leaving the mask. So fewer droplets are emitted. A second key component of wearing a mask is this. It also slows the velocity of the air coming out of the mouth. So if I cough or sneeze, if I have a powerful cough, I can project maybe 25 feet or more. If you're wearing a mask, it slows down the speed of that projection, how fast the aerosols and droplets are coming out of your mouth. So it limits how far you can spread this to other people. So mask wearing is absolutely critical. We should have universal mask wearing. There's really not a reason not to do it. We've been on record for a long time encouraging this, and I'm glad to see that at least some leaders, mostly at the state and regional level, are encouraging this, even requiring it. There are ways to don and doff it, which is the language we use for taking it on and off.
When people take off these masks, they're often just putting them anywhere. What do they have to do in terms of safely storing them?
Yeah, good practice. When you take off your mask, you take it off by the straps. Don't touch the mask itself. Hang it up. Let it dry out in the air for some amount of time, and then wash your hands immediately. Right? If you think about what a mask is doing, you're saying that I'm wearing it because there's a potential I'm emitting infectious particles, or I'm in the presence of other people who might be emitting. So the idea is, if you're wearing a mask, you're admitting or acknowledging that mask is capturing infectious particles. You should treat it as if it has done that. So when you take it off, you hang it up, it should be washed frequently or exchanged out if it's disposable, and you should be washing your hands immediately after taking it off. If it's sealed up, I think this is very intuitive. I know this is not rocket science. If someone keeps coughing and you're not letting the building breathe, what's going to happen is that the concentration increases and the intensity of your exposure will stay higher. So you can minimize that by even just cracking open windows just a little bit. Yes, it does.
if the virus were spread only by large droplets that quickly fall to the ground, then if I'm past, say, 6, 7, 8 feet, I would think I'm safe, right? But you're saying there's something else going on.
Yeah, there's two things going on. One, the 6 foot number isn't a magical number. I'm really glad from a public health messaging perspective that that has stuck, because it gives people something to target and think about, and it is related to the science in some way. But it's not a bright line. Even large droplets can extend beyond 6 feet. A cough can extend beyond 20, a powerful cough, beyond 20 feet. For airborne exposure, these can spread out in a room, and so the distance matters, but also if you're further away, you can still be exposed. So this magic, the 6 foot number is not a magic number. You want to stay 6 foot as a minimum. The further away you are, the better.
How do we stop from freaking people out by telling them that there's airborne transmission? That means if you're in any room, these tiny little particles could get to you somewhere even way across the room. How should people think about their risk if they're in a room and you're saying airborne transmission is important and they're way across the other side of the room, say 15 feet away? Do they have to worry, or how much do they have to worry?
Yeah, I don't think airborne transmission is something to be feared or should create a lot of anxiety. The really important thing here is that people have to be aware that it's happening. And once we're aware it's happening, we can apply appropriate controls. And that actually empowers us to take action to reduce our risk. The way I like to think about this is using something we call the hierarchy of controls in my field of worker health and safety. There's 5 parts to it. It's a layered defense approach, and it gives you some sense into how to prioritize the control measures. So here are. The first one is to eliminate the hazard. And if you think about this in terms of work, the idea would be to prioritize work from home or limit the number of interactions you might have. Second in the hierarchy is substitution. So can you just identify those core people that really have to be back in an office, or the errands you have to run? You have to go grocery shopping. You have to go to the pharmacy. Third are engineering controls. These are healthy building strategies like bringing in more fresh outdoor air. Fourth are administrative controls, physical distancing, avoiding long queues, managing flows of people. And fifth is PPE, for personal protective equipment like mask wearing.
So now you want to go outside. Mask, no mask, what do you do? So it's trying to do what's reasonable, knowing nothing's 100% effective except for staying by yourself inside and not seeing anybody.
Yeah, but that's, I'm really a firm believer here that we can save lives and the economy. Mental health is really important too. We do need that social connection. I hate the term social distancing. I love physical distancing. We want to stay connected to others. This is really important. Here's how we can approach it. We can manage these risks, right? If we just stay smart, if we are careful about the decisions we make, place it in the context of who we're with. Are we indoors? Are we outdoors? What's a person we're with? What's their personal risk? What's your personal risk tolerance? We just have to make some smart decisions here and do our part in minimizing the spread here. But we do need that social contact. We do need to talk to our neighbors. We do need to see our family and friends. We just have to do it a little differently than we've done it in the past. No more handshakes, no more hugs, stay a little bit further apart, wear your mask. It's a sign of respect for the person you're with.
No more hugs?
For a little bit.